Oh, there we go. So plan is to eventually post this meeting online as part of this series. So we'll go ahead and dive in here. So I just want to start with an agenda for this evening. So I'm going to spend a few minutes up front introducing both this series and then myself as the primary speaker. Again, I think it's important for folks to have some context about how this series came about and how it's going to work. And then I'll share a little bit about my own background as well. And then we'll dive into kind of the meat of the topic tonight. So we're going to start with who is Milton Friedman. We'll talk a little bit about a framework, it's kind of simplistic framework for U.S. healthcare or healthcare in the United States, and we'll use that framework throughout the 6-part Business of Medicine series. And then we'll talk a little bit about defining success in healthcare, how provider organizations and payer organizations define success and really how they measure success. So we'll focus in on measuring profits and also measuring patient outcomes and how that's done and how that's considered. And then we'll summarize some of the competing interests and we'll share some final thoughts. And then we'll have an optional Q&A and discussion time at the end of this evening. So let me start with how this series came to be. So I think this is probably not news to anybody on this call, but the percentage of family physicians who are employed continues to rise, particularly among younger physicians. So I apologize if this little snippet's difficult to read, but this is actually a cutout from testimony before Congress in 2023 by the AAFP. And I'll just read this. Proportion of family physicians who are employed continues to grow each year, with 73% of all AAFP members and 91% of new family physicians, those who are 1 to 7 years post-residency, working as employees in a wide range of organizations from small independent practices to Fortune 100 employers. This shift is dramatic, considering only 59% of AAFP members reported being employed in 2011. So I think we're all aware there's this trend of moving towards an employed role. This has been recognized by the WAFP, and there's been efforts over a number of years to figure out how best can we support employed family physicians. And I think probably related to this comment that physicians are feeling less autonomy and control than ever. And some of you may have seen, this was an article in the New York Times called Why Doctors and Pharmacists Are in Revolt. I think this was from December of this year. And the subtitle is interesting here. Once accustomed to a status outside the usual management labor hierarchy, many health professionals now feel as put upon as any clock punching worker. And the article went on to describe physicians forming unions, which is a new concept, right? Physicians have typically functioned outside of that typical framework, but increasingly physicians, even residency programs, I think Northwestern's residency program or fellowship program decided to unionize. So again, clearly physicians are feeling less autonomy, less control. And so this series is really born out of that context. And it's, I would say, part of Washington Academy of Family Physicians' response to this worrisome trend. And the worrisome trend, to be clear, is not the employed role. It's the fact that family physicians feel less autonomy, less control, less influence, less voice, less ability to positively impact the care of their patients. So what is the goal of the Business of Medicine series? In 2 words, it's simple. The goal is really around physician empowerment. So that's really what we're trying to aim for over these 6 sessions, is to provide knowledge and education and context and a framework with the belief that that knowledge then translates into power. And so to put it a little more succinctly, with additional knowledge and understanding, our hope is that physicians will feel empowered to regain a sense of autonomy and control, which they can then use to improve patient care and their own professional satisfaction. And I think these days, many family physicians feel like they're sort of fighting an uphill battle. And I hear from some of them this perceived trade-off between, in order to provide great care, I kind of have to sacrifice my own sanity and well-being, or on the flip side, can really lean into what's good for me, and the system's not really set up to support patients the way we would like. I also hear a lot that family physicians in large organizations feel like they don't have a voice. And so our theory here, our premise is, knowledge is power. And so with additional knowledge, additional frameworks to understand how kind of the business of medicine actually functions, that family physicians will have more control. Let me introduce some of the facilitators for the meeting tonight. So again, this series is really organized by the Washington Academy of Family Physicians Professional Affairs Committee. The WAFP has a number of different committees. We always love adding new members to the committee. So if that's of interest to you, you can go on the website, wafp.net, and find opportunities to get engaged. Jordan and myself are the physician co-chairs of the Professional Affairs Committee. Jordan, as you can see, works in Spokane, and I work up in Bellingham, so we got both sides of the state covered. And then we have two WAFP staff members. Alyssa, really, she's the director of pipeline and practice relations. She's really the facilitator of the Professional Affairs Committee. Jordan and I refer to her as the brains behind the operation. And then we also have Lynn, who technically is not a part of the Professional Affairs Committee, but is helping to facilitate tonight. So Lynn, we're making you an honorary member for this evening. And then I mentioned up front that this session is going to be recorded. If you have questions throughout the session, we're not going to interrupt during the presentation. So you can throw those questions into the group chat, or if you're worried about confidentiality, you can send those questions directly to Alyssa, and then she will bring those forward at the end and will not share your name. So again, if it's more comfortable to direct the question directly to Alyssa, please feel free to go ahead and do so. So what is the business of medicine? Again, the title of this series. So I think of the business of medicine as the non-clinical component of how healthcare works. And it's, I think, as you all know, you're probably here because you recognize that this non-clinical aspect of healthcare is not something that's typically taught through medical school or residency and such. But once you're out in the real world practicing, you realize it becomes a pretty significant component of us being successful, effective physicians. So this can be difficult to distinguish from the care itself at times, but it's really, I think of this as the world of finances, operations, organizational strategy, how organizations make decisions, what the different competing interests that they're trying to juggle are. That's really what the business of medicine is. So this series is going to be a little different, obviously, than your typical CME, but I think our goals are very similar. Again, it's around empowerment. It's around helping you to become a better doctor so you can apply these concepts and knowledge to better serve your patients. And then in terms of logistics, for each of these 6 sessions, what we're planning is 45 to 60 minutes of presentation, again, which will be recorded. And then we'll follow that up with the Q&A session, 5, 10, 15 minutes of Q&A. And then what we'd like to try tonight is just splitting into discussion groups for those that are able to stick around. And Jordan and Lynn will facilitate one discussion group, and Alyssa and I will facilitate the other. And hopefully at that point, folks maybe feel comfortable turning their cameras on. We'll shut down the slides. And again, it'll just be kind of an open, free-flowing discussion. And then this is a really important piece of this. This whole series is hopefully built around presenting information in a format that's helpful to you all. And those of us that have been involved in creating it, we would love any feedback that you can provide. And so Alyssa will send out a survey. I would just put out there that really honest, constructive criticism is really super helpful. So I think all of us that helped to develop this, we're not tied to one specific approach. And if there are certain pieces of information or certain approaches that you think might be helpful, we would be very open to that. Again, the idea is to make this time exceptionally useful to you all. We know that everybody is busy and we want this time to be as high value as possible. So please don't hold back on feedback. If you think any piece about it could be refined, please share that. We will not take that feedback personally. So I'm going to be the primary speaker throughout the 6-part series. There may be other people who join along the way, but I wanted to share just a little bit about me, just so you have some context for the perspective I'm bringing to this. So first and foremost, most importantly, this is my family. My wife is a psychologist, and we have a 15-year-old daughter and a 12-year-old son. And this is us up in the North Cascades this past summer. If you've not been up there, it's absolutely worth the trip. A little bit about my background. I grew up in Washington, grew up outside of Seattle, town called Woodinville. Born and bred Washingtonian, feel very passionate about healthcare in this state. I did my undergrad work at Stanford University, majoring in biology because I knew I wanted to go into medicine. But I also have a degree in economics, which is kind of an interesting tangent, and I'll spare you the details of that, but obviously creates a little different perspective. And then after I graduated from college, I spent a couple of years working for a company called BCG, the Boston Consulting Group. And this is a management consulting group that does strategy consulting for large companies around North America. So I worked with Microsoft and Wells Fargo and TELUS, which is a Canadian telecom. And it's really about solving strategic business problems. And ironically enough, I walked away from that job to start medical school at the University of Washington and naively thought to myself, nah, that was fun. I'll never think about business the rest of my career. And that has turned out not to be the case. So did medical school at the University of Washington, residency down in Southern California at Glendale Adventist, and then finished up my training 15 years ago in 2009 and joined an organization called Family Care Network. And I want to provide just a brief introduction to FCN so that there's context and framework for, again, my experience coming into this topic. But first of all, my first decade with FCN, I did full spectrum family medicine, outpatient clinic, hospital, inpatient work and OB. And then about 5 years ago, took over as president and CEO of the organization. And so FCN is a totally independent, physician-owned, family physician-run primary care organization in Whatcom, Skagit County. And so the work I've been doing for 5 years is all of this business of medicine day in and day out. I still get to practice clinically a couple mornings a week in one of our rural health clinics, but this has been a big piece of the work that I've done over the last 5 years. And that period of time has been a really interesting education learning process for me. And that, again, that's part of what I'll bring to the presentation here. So we should always declare conflicts of interest. I don't have any as it pertains to this subject, but opinions, yes. And I would state that, again, as we think about these presentations, you could ask 5 different people to present this topic and they would present it in very different ways. This is just, again, my perspective, my opinion. There won't be a lot of hard data throughout these presentations. It's really about framework and ways to think about things. But again, my opinions will certainly be interspersed throughout. So, all right, so let's dive into the topic for tonight. So it's, again, how healthcare organizations define and measure success. That's really what we're focused on. So I want to start with a question: who is Milton Friedman? So this is a picture of Milton Friedman, and you might be thinking, why the heck are you starting with that? So who is this guy? So Milton Friedman, I describe him as a controversial Nobel Prize-winning American economist in the mid-20th century. As I told you, I was an econ major, so I learned about Milton Friedman a long time ago. Friedman was an economic advisor to President Ronald Reagan, and that's significant because he had massive influence in Reagan's economic policies. And remember, Ronald Reagan became president at a very interesting time in American history because we had about half a decade of stagflation, which was really difficult for the economy. And interestingly, many of Friedman's ideas became kind of widely adopted into economic policy and then business school education, and thus have heavily influenced corporate America today. So he had, I would say, an outsized influence on how corporations in the United States do their business and how they operate. So in 1970, Friedman published an article in the New York Times. It was titled "The Social Responsibility of Business is to Increase Its Profits." And this was long before my time, but I want to share a couple of quotes because, again, this article, this premise had significant impacts in how capitalism in the United States have moved forward. So this is one of the quotes from the introductory paragraph. So businessmen believe that they are defending free enterprise when they claim that business is not concerned merely with profit, but also with promoting desirable social ends, such as providing employment, eliminating discrimination, avoiding pollution, and whatever else. In fact, they are preaching pure and unadulterated socialism. So kind of ironic that socialism 40 years later or 50 years later now it continues to be a threat for all things that could go wrong in America. But what he's saying is a business working for anything other than profits is kind of BS. He concludes with this sentence that I've split into 2 pieces. There is one and only one social responsibility of business: to use its resources and engage in activities designed to increase its profits. And again, that's a pretty significant statement. And I think in 1970 was a particularly significant statement. Now, lest you think Milton Friedman is a pure selfish capitalist, this sentence does conclude with saying, so long as the organization, stays within the rules of the game, which is to say engages in open and free competition without deception or fraud. So in a future session, we'll circle back around to that statement. But the big message here is Friedman's basically saying success in business equals increasing profits. And again, an unusual idea maybe for the time, but an idea that started to integrate in business schools and US economic policy and such. And it's interesting to think we now have an entire generation or multiple generations of folks who have come out of MBA programs believing that this is the one and only accepted definition of success for a business. And I think it even invades our thoughts when we hear things like, oh, Meta's laying off a bunch of workers. We probably think, well, that sucks, but they are trying to drive profits. That's what they're supposed to do. Or Amazon is raising the cost of an Amazon Prime subscription. Annoying that I have to pay 20 more bucks, but they are trying to drive profits. And we just sort of implicitly accept that. Again, those ideas, I would say, largely date back to Friedman and this premise that success for business ought to be defined by increasing profits. So that's the kind of background and framework for part of this presentation. Let's turn our attention to healthcare. And I mentioned that I would share kind of a simplified view of healthcare in the United States. So this model, this 3-part model, is one that we'll refer back to throughout the 6-part series, and we'll focus on different components of this model. And so in the top left is provider organizations. So these are physician groups, health hospitals, multi-specialty groups. It's the groups that actually provide the care. On the top right, we're calling just payer organizations. So think of these primarily as insurance companies, although CMS is also a payer, state Medicaid is a payer as well. And then in the bottom is patients, who always should be at the center of the work we do, but aren't always at the center of the work we do. So again, the 3 Ps: providers, payers, and patients. And I would just call out there are arrows reflecting the fact that there are relationships and interactions, contractual, financial, other interactions that occur between these 3 groups. And this really, in a somewhat simplistic view, is what healthcare is in the United States. So again, over this 6-part series, we'll kind of zoom in on different pieces of this, try to make sense of them. And the hope is that at the end of all this, we have a clearer picture of how this whole puzzle fits together, what happens really behind the scenes in the business of medicine, and then how can we effectively, as physicians, family physicians, navigate in that world. So tonight, our focus is going to be on provider and payer organizations. And again, it's around how they define and measure success. So that's where the focus area is. And with the exception of CMS and perhaps state Medicaid, I would just point out that provider and payer organizations are businesses. That's what they are, organized in a whole variety of different fashions. C corporations, S corporations, LLCs, PLLCs, even nonprofits. Nonprofit is, of course, a tax designation, but a nonprofit has to operate in many ways very similar to a business as well. So like every other business, provider organizations and payer organizations must define success, right? Every organization has to say, this is what we're aiming at. This is our direction that we're heading. This is how we know if we are doing our job well and achieving our goals. And so it really is about what is our definition for success. And I would point out that every healthcare organization typically has a mission or a vision statement, and that is the sort of public-facing stated sort of how they're going to operate. I would say that doesn't always match how an organization actually functions and what their true definition of success is. So I'm going to propose a simplified, just for illustration and framework tonight, a simplified defining success spectrum. And again, there's lots of different considerations for these types of organizations, but we're going to make this really simple. And on one end of this spectrum, put profits. And Milton Friedman would be very happy with that's how healthcare organizations should define success. And at the other end of the spectrum, we'll put patients. And I actually considered putting just people there because it's patients, but it's also providers, and physicians. It's also employees and staff members. How an organization thinks about the people it serves, but for the sake of simplicity, we'll really focus on patients. We are, after all, in healthcare. And so you could think of this spectrum and say, well, geez, every organization could be plotted somewhere on this spectrum, and I could sort of just drop a line and say, this organization perfectly balanced profits and patients, or this organization's all about patients or all about profits or what have you. I would like us to take the framework that this is a little bit of a scale. And so it's profits and patients and how they are held in relative balance within a healthcare organization. And again, this is true whether it's a provider organization or a payer organization. There is this spectrum and this scale and this balancing act. So let's take a look at different organizations, how they define success, and then describe those organizations. And so the first organization I would like to propose is sort of this one. So this is an organization that says, we are 100% about patients. We put all our weight, energy, and effort into patients. We don't even think twice about profits or profits, maybe the financial operations of the organization itself. And I would call this volunteering. I think sometimes as physicians, we think this is exactly how healthcare should be. It should all be about patients, and we shouldn't think about the business aspect. But without any consideration to the business aspect and the financial aspect of the work that we do, you don't have a sustainable business model. So this is great, but this is really a model of volunteering, not a model of a sustainable organization. The opposite extreme of that model would be a picture something like this, right? So this is a picture where all the weight and focus is on profits with complete disregard for patients and people and such. I would describe this as Milton Friedman's dream, because success is defined purely as profits. But I would also state, and I think we would all acknowledge this type of organization also wouldn't be sustainable, right? I mean, if you really didn't give 2 thoughts of effort towards patient care and you were totally focused on profits exclusively, you wouldn't retain patients for very long. It's not a formula for a sustainable organization. So let's look at a couple other examples. So this is one where both patients and profits are held in balance, but there's certainly a little bit more weight towards the patients than the profits. And so I would describe this as a patient-focused organization, yet fiscally responsible. And so again, this is an organization that when push comes to shove, tends to err on the side of what's good for patients over what's good for the financial bottom line, but acknowledges the reality that in order to have a sustainable organization, we have to have a sustainable kind of financial model, business model underlying it. So again, this is always a delicate balance for healthcare organizations because, as I said, it's not really one or the other. But I would hope that this is where every healthcare organization lands, that success is defined by patient care, patient outcomes, but there is some acknowledgement paid to the financial realities of operating a business. And if for no other reason than if the business isn't sustainable and crumbles, then physicians don't have jobs, employees don't have jobs, and patients don't have providers, right? So we want to create a model where there is long-term sustainability for patients. And then this is another one that you certainly see out there. So this is an organization that, again, is giving some weight both to profits and to patients, but when push comes to shove, they tend to err on the side of profits over patients. And I would simply call this a profit-focused healthcare organization. And so it's not that they don't care about patient care, but the patients are really primarily viewed as a means to profitability. So that's somebody who says, our goal is to drive profits. In order to do that, we need to keep patients and such. So we have to put enough energy into patient care to continue to drive our profits. And again, some of you may have familiarity or experience with organizations like this and how that trickles down and translates into how decisions are actually made within the organization. So a big take-home message with this scale of defining success from profits to patients is that healthcare organizations really must consider both profits and patients to be sustainable. The real question here is how much they lean to one direction or another. And again, as we go throughout this series and as we think about physician empowerment, recognizing this reality, recognizing that there's a bit of a balance that these organizations are facing, I think is a really key thing. And again, I sometimes naively hear physicians say we should only be about patients and shouldn't think about anything else. And I 100% agree that patients should be the primary focus, should be the definition of success in organizations, but there has to be some attention paid to the financial realities of an organization in order to ensure sustainability. Let's look at provider organizations. So we're going to do a little deeper dive on profits and then patients. And so we're going to start with looking at provider organizations. How do they define and measure profits specifically? So I think you're all familiar with this picture that this is sort of accounting 101. So revenue minus expenses equals net income. And so let's explore this a little bit more so that we understand when we're talking about this model, what things are we thinking of that are key inputs and drivers to this. So let's start on the revenue side. So where does revenue come from for provider organizations? Primarily, it comes from payers and from patients, right? And so payers, that's the contracted reimbursement that we achieve for the care that we provide. So in a fee for service, that's the amount of money we're paid for each visit we do. Maybe we have capitated agreements that pays us a certain way. We do have a future session in this series all focused on how payers pay providers, provider organizations for the work they do. This may be incentive payments that come from payers as well. So it could be a variety of different things. We forget that patients also play a role in the revenue we generate. So they pay copays, co-insurance. If they have high deductible plans, they're often paying directly out of pocket for much of their healthcare coverage, particularly in the earlier parts of the year. So most of this revenue is generated from seeing patients and the reimbursement that comes from seeing those patients. But it's worth pointing out that provider organizations do have other revenue sources. So investments is just money they generate from the corporate reserves that they invest. And I was looking the other day at a pretty large hospital in Western Washington, hospital system in Western Washington. And 1 or 2 years ago, they had $30 million in investment revenue. And so, or investment profitability, basically. So they invested God knows how much money into the markets or other ways. And this returned a massive profit. Again, that's a piece of their revenue. Some organizations are eligible for grants, obviously. Donations for nonprofits or foundations that can filter into provider organizations as well. But again, revenue largely primarily comes from the work we do, taking care of patients, seeing patients, taking care of patients. And obviously this would include visits with doctors, different procedures that are done, hospital stays generate this revenue as well. So that's the revenue piece of it. Again, important to understand where this comes for provider organizations. And then what about expenses? So expenses is really everything that it takes to run the organization. And you really have to take a very, very broad perspective of that. So there are some obvious things like staff wages and benefits, right? You got to pay for nurses, you got to pay for front desk staff, you have to pay for hospital staff, yada, yada, yada. This includes wages for middle management, folks that aren't providing direct patient care, aren't interacting with patients, and even wages for executives. It's fascinating for nonprofits. You can usually go online and figure out reimbursements for senior leaders and such, and just gives you an interesting framework if you understand how much folks are paid to do their work, particularly those folks that aren't directly impacting patients or working with patients. Occupancy is always a big expense, so that's really rent and all things related to that. So it's rent and janitorial and utilities and such. This would include corporate offices. If you have never been to a corporate office of a healthcare organization, it's interesting. It tells you a little bit about the organization, how it operates and what it prioritizes. Technology, obviously, EMRs, computers and such, supplies, all the different supplies we need for the work that we do. Administrative services, that's often centralized things like HR and finance and billing and IT and such. Physicians and providers in some organizations, when they're employees, they get paid directly. They are salaried employees and they are viewed as an expense for the organization. Marketing costs are huge. I always wonder when healthcare organizations rebrand themselves, because that is millions upon millions of dollars that are coming out of expenses that aren't being invested in other ways into the organization. This is not a comprehensive list. You can think of expense as every dollar it costs to operate the organization, and it is a very long list. And so revenue minus expenses equals net income. And if that net income is positive, you have a positive net income, we call that a profit. And if and folks will refer to that as being in the black. And if there is a negative net income, that is a loss, and folks will refer to that as being in the red. And so obviously any provider organization, if they are in the red year after year after year, that is not a sustainable pathway, right? So they have to figure out how to continue to maintain at least a neutral net income would allow you to continue to function. Again, some organizations are really interested in driving up that profit as much as possible. But again, this is the view. The revenue less expenses equals net income. And this framework is important to understand, because as we're thinking about advocating for change within our organization, understanding the financial realities of this of your organization is a pretty significant piece. So final point on this slide, and I think this is a really significant one, and we'll circle back around to this. Physicians are the primary driver of revenue generation in any healthcare organization. And that's meaningful because that creates leverage for physicians, right? Healthcare organizations don't work without physicians. Even hospitals, you think, oh, hospitals, they get all those hospital charges and such. Not really. If there aren't physicians there to take care of patients, they can't admit anybody to their hospital. So I think sometimes we as physicians feel a little bit powerless in this big system, but we are the primary drivers of revenue generation. And I would take that a step further. And again, we'll circle back around to this, but now is an exceptionally good time to be a family physician because so much of healthcare is shifting towards a value-based care model and recognizes that healthcare costs way too much. And the solution to that is more primary care providers, more family physicians. We provide high quality, cost-effective care. We are helpful in terms of value-based care arrangements and such. And so again, one of the take-home messages from this whole series is, as family physicians, we should not feel powerless. We should feel immensely empowered. We should recognize the leverage we have. We should recognize the really unique time that it is to be a family physician, and how, if we understand how this whole business of medicine functions, we can use that to our personal benefit, but probably more importantly to the benefit of the patients that we serve. So this is the provider organizations, how they measure profits. Let's look at the same thing for payer organizations. So again, revenue minus expenses equal net income. So payer organizations, these are largely insurance companies, but they are folks that we partner with. That provider organizations, partner is maybe not the term you would think of. Sometimes people think that we fight with insurance companies. It depends. Sometimes there can be a partnership there. So how do payer organizations generate revenue? Well, that really comes from premiums, right? They get paid patient premiums. That's for commercial plans, and then for Medicare Advantage and for often for Medicaid arrangements, the premiums essentially come from the federal government. And we'll talk a little bit more about how those are structured, but revenue for payer organizations comes through these premiums. And then these payer organizations, remember, they're insurance companies, so they are legally mandated to have massive reserved funds, hundreds and hundreds of millions, if not billions of dollars, many of them. And that money is typically invested. And so they have significant returns on investment, often much, much greater than provider organizations. And sometimes you'll hear funny stats like, oh, this insurance company lost X amount of dollars last year. And it's always interesting to separate out, did you lose that money because the stock market had a down year and you just lost investment money? Or did you actually lose that money on the premiums and the cost of the care that you provide? So again, this model is a little different. So, for payer organizations, again, that the number of patients they take care of and those premiums they generate is really the key driver of revenue. And then expenses, the big expense for payer organizations is paying for providing care to these patients that they are responsible. And payer organizations, interestingly, refer to patients as members. That's what they call them. So they are providing total cost of, or they are investing money to provide coverage for healthcare expenses for their members. Part of the reason why our payer organizations are really keen on primary care providers is we tend to provide very cost-effective care. And so again, if we can leverage that, that can be a beneficial thing. That's the biggest bucket of expenses for payers. But remember, the payer organization actually has their own organization. So they have internal staff members who they have to pay wages and benefits. They have occupancy, they have technology, they have administrative services, they have marketing, they have all these internal organizational costs as well. So their two big expenses are cost of providing care to their members and then cost of operating their business. And then similarly, net income that's positive is a profit, net income that's negative is a loss. Interestingly, because of the massive reserves that payer organizations have, they often can tolerate significant losses, often for years, and it's still a sustainable model for them. I would just call out that we talked about payers and we included CMS. This model looks different if you're a traditional Medicare administered by CMS. CMS is Center for Medicare and Medicaid Services. They administer traditional Medicare. For them, revenue is really tax dollars that get devoted to administering Medicare. Expenses is obviously all the costs that they pay out to administer Medicare, so all the benefits that they cover. And then obviously they have some internal costs of the organization itself. I think you are all aware that CMS runs at a net negative and has for a very long period of time. And as a result, more money is being devoted to providing money to CMS to provide care for traditional Medicare patients. And I think you're all aware that healthcare costs are eating up a greater and greater piece of government spending as time goes on. So not really a sustainable model. But when you think about why is CMS innovating and creating these new models, there's a model called Making Care Primary that some of you are familiar with. Washington is one of 8 states that's going to be a pilot state for this new innovative payment program from CMS. What they're really trying to accomplish there is to figure out how to make healthcare more affordable. And the interesting mechanism with Making Care Primary is exactly as I said, it's shifting more funds to primary care providers and rewarding them for taking really good care of their patients. So again, I think there's this sort of coalescing agreement across the healthcare industry that the solution to much of what ails healthcare in the United States is to get more patients connected to primary care, have more primary care providers, and let them provide that high quality, cost-effective work that they are so good at. All right, let's switch gears. So that was the profit piece. Now let's look at the patient piece. Remember, we talked about that spectrum from profits to patients in terms of how we define success. So how do provider and payer organizations define and measure? We'll just use patient outcomes, but we're really focusing on that patient end of the spectrum. So again, I would say the first bucket here is around patient experience. And so how do they define and measure that? And so measure can mean in statistical ways, but a measure can also be what things they track and pay attention to and invest in and such. So the most common way we think about patient experience measurement is through assessing patient satisfaction, usually through surveys, Press Ganey and such. Those surveys, as you all aware, are always small response rates, skewed values and such. How these organizations prioritize doctor-patient relationships helps give you a sense about the patient experience piece. Monitoring, improving access and convenience. So that could include how quickly can you get in and see your provider, or how many providers are open to taking new patients, or even something like how long does a patient wait on hold when they call the clinic or the office in order to talk to a front desk staff member. Tracking timely and effective communication with patients. Again, that can be responding to MyChart messages as an example, or other communication avenues. Responsiveness to patient complaints. And then this one, reducing physician burden through technology and team-based care, recognizing that gives physicians, family physicians, more time to focus on those doctor-patient relationships, and all that's encapsulated in this idea of patient experience. And then the other one that we're all familiar is the actual patient care, right? And so we would separate out care from experience. I think you all know that patients tend to rate their doctors by how nice they are and how easy they are to work with and all the intangible interpersonal pieces. And doctors tend to rate other doctors by their medical decision-making and clinical acumen and such. So this is really the medical decision-making piece. So supporting appropriate and timely medical decision-making, expanding provider education and scope of practice. I personally am a huge believer that family physicians should practice as broadly as they can and manage as many different things as they can, and should be given the time and the permission to be able to do that, because we do those things in a more cost-effective way. Tracking and supporting what in Family Care Network we refer to just as measurable quality. So these are the classic kind of HEDIS measures: preventive care, cancer screenings, vaccines, chronic disease management, and such. In my organization, we're always careful to say that is called quality, but it is not what makes a quality physician. We measure those things because they are objective, numerical, and statistical. We don't measure those things because that's what defines an excellent family physician. And for better or for worse, healthcare as an entire entity has adopted these measurable measures as comparing different physicians and different organizations and such. But again, we should ideally perform well on those measures, but it's not the be all end all in defining what a quality family physician is. And then tracking and supporting appropriate utilization. So I don't know if y'all are familiar with that term, utilization, but it really gets to how we effectively manage cost for patients. And so I think as primary care providers, what we're looking for is ways to ensure that patients get the right care at the right time, in the right place, by the right provider, right? So when we think about ED visits, emergency room or emergency department visits, is that really appropriate? What are we doing to keep patients out of the ED if they don't need to be there? What are we doing to avoid admissions or readmissions? Are we thoughtful with our prescription patterns, generic versus brand name? What about utilization of advanced imaging or specialty referrals and such? How is the organization supporting appropriate utilization moving forward? So again, this might look a little different if you're a provider or payer, but basically when we think about patients, this is what I think about: it's patient experience and patient care as the key components of that. So let's move back to this view. So how does a provider organization succeed based on their definition of success? So again, profits on one extreme, patients on the other. Let's talk about how we succeed in the profit world, right? So really, we're talking about driving up net income, which is profits. And really to do that, as we remember from that previous picture, we want to increase revenue and we want to reduce expenses. And that drives up a positive net income or profit. So what would a healthcare organization do if they are interested in driving up, or what would a healthcare provider organization do if they were interested in driving up profits? They would do these types of things. They would increase revenue by insisting on more visits. I hear stories about family docs being told, you have to see X number of patients a day, and now we want you to see 3 more, and now we want you to see 5 more and such. More visit volume generates more revenue. More hospitalizations generates more revenue. More procedures generates more revenue. Hiring more specialists generates more revenue. Investing in highly profitable services generates more revenue for the organization. I mentioned that I did residency in Southern California, and my last year of residency, I had a conversation with one of the executives in my organization, and they had just invested an inordinate amount of money in a joint replacement center and a cardiovascular institute. And I was speaking with one of the executives. I can't remember if he was the CEO or not. And I said, hey, why did the hospital just spend tens of millions of dollars on these 2 things? What it seems like the community really needs is a lot more primary care. Like, we need family docs and we need pediatricians and such. And he looked me dead in the eye and said, there is no money in family medicine. And that was the explanation. So that's why they devoted, 10, 20, 30, 40, $50 million to do more joint replacement procedures and advanced cardiac procedures, because that's really where the money was. It didn't reflect the community need, but it was their way of driving up revenue. So that's the increased revenue piece. And then what about reducing expenses? So less staff. Staff costs a lot of money, not just their wages, but their benefits. Lowering physician income, or maybe setting productivity thresholds that are so unreasonable for physicians that results in a pay cut to those physicians. Less administrative support in all sorts of ways. Less investment in technology. No, you can't have a scribe. No, we're not going to do Dragon. No, we're not going to explore ambient transcription programs and such. And then eliminating less profitable services. I am familiar with an organization that's community or a hospital that's made a decision to eliminate outpatient palliative care. Like, talk about a punch in the gut for a local community, right? That's a hard thing to eliminate, but it was done because it wasn't profitable, right? And so not really in the best interest of the patients per se, but certainly in the best interest of the financial bottom line. So this is a picture of a provider organization that's trying to maximize the profit piece of it. What about an organization that really wants to focus on patient care? So how do you improve patient experience? You support doctor-patient relationships. You expand patient access. You invest in technology and team-based care. You respond to patient concerns. And how do you improve the actual medical care provided? You support and expand provider education, including scope of practice, and support effective medical decision-making. You develop systems to avoid inappropriate utilization and support quality, and the list goes on. And a really obvious statement to make here is how these 2 yellow buckets are at odds, right? On the right side, what we're talking about is investing resources, investing dollars, investing time, hiring more staff, putting money towards technology, training people better. This is costly. It leads to better patient care, better patient experience, and better patient outcomes. But boy, it sure doesn't help the financial bottom line. And that conflict and that tension is a lot of what we see. It works the other way as well, right? As family physicians are told, see more patients, we're now going to reduce you to 7-minute visits, you're going to see 32 patients a day and such. How can you provide good care and a good patient experience? That's not time to invest in relationships and such. So there is a tension between these two pieces, profits and patients. And again, thinking through tangibly, how does that play out, might provide some illustration to some of what you've experienced within your respective organization. So let's do the same thing on the payer side. So that was on the provider side. So let's look at how a payer organization might drive up profits. So again, increasing revenue, reducing expenses. So increasing revenue, growing membership. And again, insurance companies call patients members. So they all want to grow membership. They might increase premiums. And then we'll talk a little bit about this in a future session. But for some of these plans, insurance companies are paid based on risk coding. So you're probably all familiar with HCC coding and such. Why do they go to the nth degree to capture every single imaginable HCC code? Because that drives more premiums, more revenue coming into the organization. So that's often the push you see. And then reducing expenses, patients feel these, right? So reduced care expense. So fewer covered services, more exclusions, smaller networks. Prior authorizations are a great example of that, right? They're trying to reduce the insurance companies, the payers are trying to reduce how much they have to pay for, so they institute prior authorizations. A couple of years back, had a conversation with an executive vice president, one local payer partner we work with, and I just asked him point blank. He was actually a family physician by training. I said, "Why the heck do you have prior authorizations?" And he said, "If I'm being honest, what we are trying to do is manage what happens in the room from behind the scenes." That's what they were trying to do. And I said, "Holy cow, that seems like that should be your job. You should let me manage what happens in the room." And he says, "Yeah, it's probably true, but we have to manage expenses, and this is a tool we use." So do prior auths lead to better patient outcomes? Probably not. Do they save insurance companies money? Probably do. So how else might they reduce expenses, reduce customer support? Your patients hear that, right? You've all heard the story. I tried to call X insurance company, and boy, I waited on hold forever and I couldn't get through. And when I did, they had outsourced me to who knows where, and I couldn't get the answers I needed and such. Reducing customer support saves on expenses and increases profits. Reducing administrative staff and less investment in technology. I was astounded to hear, this is kind of a funny story, but years ago, an insurance company we work with, I forget the question I was asking, but could they do this, piece in their technology system? Like, we needed this data or whatever. And one of the representatives from that company paused me and says, "You need to understand that we operate on a MS-DOS system. And if you're young and don't know what that means, good for you." MS-DOS was an old computer program, I kid you not, from like 40 years ago. And they said, that's still what we operate on. And we thought, how the heck is that possible? But it's really expensive to invest in technology. They were avoiding that expense. And then what about a payer organization that really is focused on patients? What might they do? So they would improve patient experience by expanding customer support, better access, better answers, having clarity in plan design. Plan design means how the actual insurance product, what are the benefits included, what are the exclusions? And if you've ever looked at your own healthcare insurance plan, it is a convoluted mess. They could just be really clear. Here's the things we cover, here's how we cover them, here's what's excluded and such. And then investing in technology obviously would improve the patient aspect of thing. And then what about improving patient care? Increasing cover services, so they cover a broader array of services, including all preventive care and such. Broadening networks, reducing prior authorizations, and again, I think investing in technology is helpful there as well. So again, a similar dilemma here, because you can see how these two yellow boxes are at odds with one another. The things you do to drive profits may be exactly counterintuitive to the things you would do to support patients and better patient outcomes. So again, that tension exists for these payer organizations as well. So let's summarize what we've talked about tonight. We've made good time through the presentation. So again, this session was really focused on how healthcare organizations define and measure success. So just to review, we started with Milton Friedman, again, this controversial economist, and his sort of driving premise that success equals profits, and just recognizing how deeply that is infiltrated corporate America across all industries. Unfortunately, that's infiltrated healthcare in many ways as well. And I think some of what we experience is the reality of that. One of my personal biases, for what it's worth, is that physicians ought to lead healthcare organizations. And I think many of you know that in larger healthcare organizations, physicians often do not lead. Leadership is through MBA finance types folks who went to business school and learned Milton Friedman's ideas and have put those into use and are often now driving first and foremost to profits. We talked a little bit about this model, the 3P model, so providers, payers, and patients, and the respective interactions between those three groups, and that being a simplistic overview of what healthcare looks like in the United States. And as I said, that is a model we will circle back to time and time again throughout this series. And then we talked about this whole idea of how health organizations define and measure success and having this defining success spectrum from profits to patients. And I want to say again, there are many other considerations. This is a massive oversimplification, but it's a mental model I've used that's helped explain why many decisions happen in healthcare, decisions that might on the surface not make sense to you, but if you understand kind of this model and how these organizations are thinking about things, often you can get a little more clarity into decision making. We went a little deeper on profits and explained how revenue minus expenses equals net income, and that's really what profits is about. And then tried to understand what are the drivers of revenue and what are the expenses, both for provider organizations as well as payer organizations. Excuse me. We did the same thing on the patient side. So thinking about patient experience and patient care as kind of the key markers for success if you're really focused on patients as the primary goal for an organization. And then spend a little bit of time walking through how would you increase revenue and decrease expenses if your goal was to drive profits. And then on the patient side, how you might improve patient experience and improve patient care if you were focused on the patient side of the spectrum. And then a big take-home message is that often these two boxes are held in conflict, and the things you do for one are often counterproductive to the other one of those things. So again, I think we acknowledge that as the tension, the nature of the work we do. I will tell you that as a leader in a healthcare organization, trying to find that right balance is a continual challenge, right? We always want to land on the side of patients, but we do have to acknowledge the financial realities that an organization faces. So final closing thoughts here, and then we'll get into the Q&A. So the first one, remember, it's never as simple as profits or patients, but must be a combination of both for an organization to be sustainable. Again, that notion that this organization is only about patients or only about profits, that's not a sustainable course. And honestly, that's not the reality of what we see in healthcare organizations. Second one, every single healthcare organization I've ever known states that they define success based on patient outcomes. That is written in there's some unofficial rule in healthcare that in your mission and vision statement, you have to state that you are about patients all the time in every context. Again, that may not always be true. The decisions that truly reveal a healthcare organization's priorities are often made behind closed doors. So executive team meetings, board meetings, et cetera, they are never the things that are posted on a website. They are never included in mission and vision statements. But these actions and these decisions are made by executive team members, board members, are often spun publicly. But I would just remind you that actions speak louder than words, and actions reveal true priorities, right? So if you're trying to understand what is this organization, any given health organization, what are they really about? Look at their actions, look at the decisions they've made. That'll really tell you what their priorities are. Don't look at the mission and vision statement. They all look the same. They all sound roughly the same. Look at their actions. And then this is a big take-home message. Understanding a healthcare organization's true priorities is step number one in the process of regaining influence and effectively advocating for change. Again, this series is going to conclude with sort of the push towards saying, now that you understand how this whole game is played, how can you go be effective within your specific organization or within the healthcare industry more broadly? And again, understanding the priorities of the organization with which you operate or within which you're hoping to have influence is really key to designing your strategies for change to be in line with those priorities. And again, that'll make more sense over time. So those are my final thoughts. We're going to move into Q&A and then breakout time, but I want to say thank you so much for joining us for tonight. And I want to say again, please provide honest feedback for how we can refine these sessions. Again, they should be useful to all of you. Any honest feedback is welcome. Constructive criticism is welcome. We will appreciate your honesty. And then as a reminder, module 2, the second in this series, which is titled How Healthcare as Big Business Affects Physician Independence and Agency. That'll take place Tuesday, April 9th, 6:30 p.m., same start time as tonight. And that one will really trace kind of the evolution of healthcare over the last 40 years, particularly for provider organizations, how they have evolved and grown into these massive entities and why that's happened and what that's meant for physicians. That's the world many of us operate in. So again, it'll be familiar, but understanding the historical kind of reasons behind that and what it has meant for us. We'll look at in that session, we'll look at, again, massive healthcare organizations. We'll look at outside investment from private equity and venture capital and what that means, and being publicly traded, and all these considerations as well. So again, hope you are able to join us for the next session on April 9th at 6:30 p.m. So let's move into a Q&A session. I would just remind, I always say this in FCM, no question is off limits. Please, if a question is in your mind, don't hesitate to put it out there. Other people, I'm sure, have the same question. We're all friends. This is intended to be a safe place. Don't feel like there is any such thing